The most common cause of conductive hearing loss is damage or a hole in your eardrum. We call this a tympanic membrane perforation. So if you look at the hearing pathway, this is damage either to the ear canal or to the eardrum itself. In the ear canal, we can get bony overgrowth called exostosis. These are little balloons that come out of the bone, and if they get large enough, we actually decrease them by doing an operation where we drill them away, and we do skin grafting in the area to open the ear canal. When you look at the eardrum, the most common causes of getting a hole in your eardrum are infection, and the second would be trauma, or getting slapped on the side of the head or hit on the side of the head. Oftentimes that comes with infection of the mastoid bone. And so the first level of treatment is just repair the eardrum itself. That's called a tympanoplasty. And what we would do is go through your ear canal or make a small incision behind your ear, take a small amount of the lining of this muscle here called temporalis fascia, or a small piece of cartilage from your actual ear that we see from the outside, and put that beneath the eardrum and rebuild it. There are times when the hole in the eardrum is secondary to an infection deeper in your ear in the mastoid. If that were the case, we would open the mastoid up, called a mastoidectomy, and then repair the eardrum, or tympanoplasty. The next level of repair is when we get into the middle ear and we start dealing with hearing loss because those ear bones are either fixed or they're dissolved from infection. Fixed ear bones can occur from an infection, or they can also occur from genetic conditions like otosclerosis, where the stapes bone actually has a dissolving of the bone with reformation of a different type of bony structure that is just like pouring rust onto the piston of a car, and it locks its movement. So as you go through the ear bone chain, let's look at a normal model. So here's your eardrum. This down here is your inner ear and your stapes. The middle of the three ear bones is the incus, and the malleus actually attaches to the eardrum. Together, these bones are connected by joints, and these joints are just like the joints you have in your knee and your elbow. It's got a pad, it's got a synovial membrane or fluid, and as these bones move, they amplify sound coming from the eardrum to the inner ear at a rate of about 28:1. That's a very loud amplification to your inner ear, which drives that stapes, giving the motion of the inner ear fluid to trigger those hair cells and give you hearing. With infection, the most common problem we have is there's separation of the joint between the stapes and the incus. There's ligaments that come off these bones, and they can be solidified as well. So we'll go in surgically, sometimes through the ear, sometimes behind the ear through an incision, do an assessment, and we make repairs. If the problem is the stapes arch, or the incus are dissolved or eroded after an infection, we have a whole series of what we call artificial ear bones, or prostheses. These are made of titanium, and the heads are made of hydroxyapatite, which is an artificial bone material. These heads are an artificial bone matrix, and this actual joint right here is flexible. So one of the problems we have with chronic ear disease, which leads to these bony erosions and infections, is that it's chronic ear disease. It continues. We're anatomically changing your ear to give you better hearing and to remove the infection, but the eustachian tube dysfunction or whatever's causing ear infections may not go away. So as the eardrum shifts over time, as your ear changes its dynamics, these prostheses shift with them. So the end game means you typically don't have to have this redone again unless you get another infection and it causes erosion. One of the tricks that was brought on by the Germans in the 1960s that we've been using since is to place a piece of cartilage that we take right off the part of your ear that you wouldn't see. It's not a separate incision. And we put the cartilage between the prosthesis and the eardrum. And that allows them to vibrate normally to restore the conductive component of your hearing. Oftentimes for people, that's the only hearing loss that they're having, and we restore that completely. There are people who have a conductive hearing loss on top of a sensory hearing loss, and what we do is we correct their ears so they're not dealing with infection and drainage, and make them a better user of a hearing aid. So we use a combination of surgery and a hearing aid to optimize their hearing. Probably the third and the most common type of conductive hearing loss I see in people who have normal ear anatomy when you look through their ear canal is otosclerosis. So again, this is the inner ear down here at the base, the stapes, and you have a normal ear bone chain. And so if we separate this joint right here, these bones all move normally. So instead of taking any bones out, what I do is I separate this joint, I use a laser, and I remove the horseshoe part of the stapes bone and the little ligament that comes off here, and we remove it completely, leaving this situation where coming from the incus with everything else still attached, we take a small titanium piston and we use a laser to what we call crimp it. We hit it with a laser, it bonds around the incus, and a typical stapes prosthesis will look just like this, where you have the piece that goes into the inner ear and the piece that comes around the incus. The laser will crimp that down and then it vibrates normally, restoring your hearing. And that would be a treatment for the condition that we call otosclerosis.